Hey everyone, if you've ever felt like diagnosing the root cause of chronic diarrhea is kind of like trying to solve a massive mystery with way too many suspects, you are absolutely in the right place. Today, in this explainer, we're taking the complex clinical algorithm for chronic diarrhea and breaking it down. We're going to turn what can be a really overwhelming diagnostic process into a perfectly solvable step-by-step map. So get ready to sharpen those clinical detective skills.
Okay, let's dive right into this. What you're looking at here is our complete master map for the evaluation of chronic diarrhea. And yeah, I know, just glancing at this flowchart, it seems incredibly dense. You've got multiple pathways, color-coded branches, tests everywhere. But seriously, don't let it intimidate you. By the end of our time together, we are going to conquer this map step by step. We'll break down exactly how to navigate from that very first patient encounter all the way to a definitive final diagnosis without missing a single beat.
To get there, here's the structural pathway we'll follow. First, spotting the alarm features. Second, our first-line evaluation strategies. Third, tracing the inflammatory pathway. Fourth, decoding watery diarrhea mechanisms. Fifth, navigating the malabsorptive pathway. And finally, reaching that final diagnosis. All right, let's start right at the beginning with Section 1, spotting the alarm features.
Before we even start dusting for clues, we have to clearly define our crime scene. In clinical terms, chronic diarrhea is strictly defined as loose or watery stools lasting greater than 4 weeks. And that strict time criteria is absolutely vital. It's the exact threshold that elevates the issue from a standard, likely infectious acute GI bug to a chronic investigation that demands our systematic approach.
Now, what's really fascinating about these red flags is how they dictate your immediate clinical reflexes. These are your primary suspects that demand an immediate pivot. If your patient has blood in their stool, unintentional weight loss, iron deficiency anemia, nocturnal diarrhea, new onset symptoms at an age over 50, or a family history of colorectal cancer, IBD, or celiac disease, you stop right there. If any of these are present, you proceed directly to a colonoscopy with biopsies, period, even if the mucosa ends up looking completely normal to the naked eye.
Honestly, the absolute biggest takeaway here is this clinical pearl. Nocturnal diarrhea is organic until proven otherwise. I mean, waking up from a dead sleep to have a bowel movement is a massive red flag. It points heavily away from functional bowel disorders like irritable bowel syndrome and just screams that there's an underlying organic pathology you need to track down.
So, assuming your patient does not have those immediate alarm features, we move to Section 2, first-line evaluation strategies.
This is our first real fork in the road. For all patients without red flags, we deploy this specific first-line battery of blood and stool tests. On the blood side, you check a CBC, thyroid function, and celiac serology, specifically TTG-IgA. On the stool side, you're looking for fecal calprotectin, a fecal immunochemical test, or FIT, and a Giardia antigen test. The entire purpose of this initial sweep is super straightforward. We just need to firmly stratify the patient into either an inflammatory or a non-inflammatory pathway.
But hey, before we wait for those lab results to come back, we need to pull a step forward. Even though it's technically step 6 on the big algorithm, you have got to do a thorough medication and diet review early. These are literally suspects hiding in plain sight. Medications like metformin, NSAIDs, antibiotics, and acid reducers, they account for up to 4% of chronic diarrhea cases. And dietary triggers are incredibly common culprits too. We're talking excess caffeine, lactose, artificial sweeteners like sorbitol, FODMAPs, and alcohol. All of these can easily mimic complex gastrointestinal diseases. Whatever you do, don't skip the basic history.
Okay, let's see how this builds into Section 3, tracing the inflammatory pathway, which is entirely based on what those first-line stool tests reveal.
Picture this. Your patient's lab results come back. The fecal calprotectin is elevated about 50 micrograms per gram, or the FIT test is positive for occult blood. What is your immediate next clinical move?
The answer is you've officially entered the inflammatory protocol. Step 1, proceed directly to a colonoscopy with biopsies. Step 2 is evaluating those findings for inflammatory bowel disease, microscopic colitis, infections, neoplasia, or ischemic issues. But I really want you to focus on Step 3 here. You absolutely must take biopsies even if the mucosa appears entirely normal during the scope. Why? Because approximately 35% of these patients will actually have histological disease hiding right under the surface. Most commonly, that's microscopic colitis, which is literally invisible without a microscope. But what if those inflammatory markers were totally normal? Well, we enter the non-inflammatory pathway, specifically Section 4, Decoding watery diarrhea mechanisms.
If your patient has watery diarrhea, you need a tiebreaker. Enter the fecal osmotic gap. The formula is 290 minus 2 times the sum of sodium and potassium in milliequivalents per liter. Our source material points out a great clinical pearl here. This is a highly discriminative yet vastly underused tool. Honestly, it's the absolute best way to separate osmotic diarrhea from secretory diarrhea.
And this brilliantly illustrates exactly how to use that gap. Let's compare them side by side. Osmotic diarrhea presents with a high gap, greater than 125. The key clinical feature? It improves with fasting. That's because it's caused by things the patient is actively ingesting, like unabsorbed lactose, FODMAPs, or other malabsorbed nutrients. Secretory diarrhea, on the flip side, has a low gap, less than 50. Crucially, it persists during fasting and is often super large in volume. We're talking over a liter a day, because the gut itself is actively secreting fluid.
Now, if your detective work points to secretory diarrhea, your next steps get highly specialized. You might order a SeHCAT scan if it's available in your region to check for bile acid diarrhea, or you might simply initiate an empiric trial of bile acid sequestrants. You also need to perform a colonoscopy with biopsies to rule out that sneaky microscopic colitis we discussed earlier, and definitely keep neuroendocrine tumors on your radar as a potential, albeit rarer, cause.
Okay, let's shift laterally. What if the primary feature isn't watery stool, but fatty stool? That brings us to Section 5, Navigating the Malabsorptive Pathway. When a patient presents with steatorrhea, or fatty stools, we follow a completely distinct investigative track. First up, check fecal elastase 1. If it's less than 200 micrograms per gram, you've likely found pancreatic insufficiency and can just treat it right then and there with pancreatic enzyme replacement. But if the elastase is normal, you move down the chain. Check celiac serology, which might lead you to a duodenal biopsy. Next, consider breath tests for small intestinal bacterial overgrowth, SIBO, and lactose intolerance. If the picture is still muddy, you escalate to formal fecal fat quantification, looking for greater than 7 grams per day, and proceed to small bowel imaging to look for deeper structural issues.
We've navigated the major pathways. Now it's time for Section 6, reaching the final diagnosis.
But wait a second, what if you haven't found the answer yet, and the patient didn't have any of those initial alarm features? Well, here's when you need to perform a colonoscopy anyway. Think of these as your delayed red flags. If the diarrhea is persistently unexplained, if you've proven a secretory pattern, if the patient is just failing to respond to empiric therapy, or if you simply have a high clinical suspicion of microscopic colitis, you gotta go in and scope. Biopsies are absolutely essential in these specific scenarios.
And that brings us to one of the most critical takeaways of this entire explainer. Functional diarrhea, or IBSD, is only diagnosed after you have methodically excluded organic causes. Please do not label a patient with irritable bowel syndrome prematurely. You can only write that diagnosis confidently if they have a normal Calprotectin, negative celiac testing, a negative colonoscopy with biopsies, and appropriate negative stool and breath tests. It is a diagnosis of exclusion, not a first guess.
As we wrap up our diagnostic map today, I really want to leave you with this final provocative thought. Our source material explicitly states that approximately 35% of patients with chronic non-bloody diarrhea actually have histological disease despite having a perfectly normal-appearing mucosa. So I have to ask, in your own clinical investigations, are you biopsying enough? Keep that in mind the next time you face this solvable mystery. Thanks for joining me on this explainer, and keep asking the right questions.